This is the second of the series of lectures I'll have for this year for my workshop. Last month, it was about documentation. So we all know what we need to do and what we need to write. So now we're going to get into the meat of what is it that we do that's different from every other psychiatric practice. And this is about precision psychiatry and how we use it to improve mental health. Okay, so let's talk about some of the evolution of psychiatric treatment. 7,000 years ago, we have what we call trepanation. It's a process of removing a skull, the purpose of relieving mental illness. This is to relieve headaches, as well as back then, they thought mental illness was a demonic possession. In the 1600s, we have the theory that mental illness is a chemical imbalance. So bleeding, bloodletting was thought to cure that chemical imbalance. Somewhat true with a chemical imbalance, but the practice of trying to treat it this way was not exactly correct. So in 1948, we have the first psychiatric medication, and that is lithium, invented by John Cade, who was an Australian psychiatrist. I believe he may have won a Nobel Prize for this. Moving forward, we have in 1950, the first antidepressant, and that was an MAOI inhibitor known as iproniazid. This was actually used to treat tuberculosis. What they saw with these patients getting treated with iproniazid, that they were happier, they had more energy. And so that's how the first antidepressant was found. In 1952, the first antipsychotic is called chlorpromazine. That is actually based out of Benadryl, first used in Paris. And the same year, the first tricyclic antidepressant was known as imipramine. And believe it or not, that came from chlorpromazine. That was the first tricyclic antidepressant known as imipramine. It came from chlorpromazine, and they noticed that it induced mania. It was the first medicine to treat depression. Cons were sedating, it's dangerous in overdose, and lots of drug-drug interactions. So nowadays, we basically just use it to help us sleep. And in a sense, it's only used when nothing else works. But as you can see, in 1987, guess what happened? All right. First SSRIs came out, Prozac. Prozac was revolutionary because it made mental health treatment a little bit more mainstream. We don't just use therapy anymore. And then there was a medicine that caused less side effects. Pros were less sedating, safer. The cons were it still took time to build up. You have your GI side effects as well as sexual side effects. So there were still psychiatric medications was not perfect. So non-medication treatment, who is this guy? We know, right? Freud, the father of psychotherapy. Great concept. Overall effective for mild to moderate depression. And still some of the cons are if the patient's too depressed, too lethargic, too anxious, they will still need medications to treat them. So let's talk about ECT. This was a way to induce seizure in a brain that can change the brain chemistry. And anybody here can tell me what are the indications for ECT in mental health?
Depression.
Okay.
Schizophrenia, which I'm used to, hallucination.
Yeah, especially what kind of schizophrenia? Catatonia, right? Yeah, when they're so psychotic, they can barely move, eat, drink. And true or false, is it used in patients with pregnancy? Yes, it's one of the more effective ones, believe it or not. When you can't give medications, it's very safe in pregnancy. So let's talk about the fun one, the last one, lobotomy. okay? Done still till the 80s, but I hear places in the world will still do them, okay? But they've fallen out of favor because they do more harm than good, left people incapacitated. Rosemary Kennedy is one of the more famous ones of these. After that happened to her, she was basically institutionalized the rest of her life. So despite of all these options, why is it we still have 10 million Americans are still depressed despite all these treatment options? And anybody take a guess why I chose that picture?
Because she doesn't know what else to do.
Well, what is she wearing?
It's correct.
Oh, yeah, right. And I think it's very, very inherent. It's almost become an epidemic also within mental health. I mean, doctors committing suicide, and now they have this program that is aligned especially just for them, so they can get help, because the stigma, right, is very, very hard to deal with, knowing that ourselves, our people in our field are struggling with this. So that's even harder for us to even try to get help. So let's talk about treatment resistance. So how do you define treatment resistance? You know, despite all the treatment you've given them, they still are not responding. And can anybody tell me what is the treatment resistance in depression? 50%. So we got a lot of work to do, right? Anxiety, 50%. Sometimes I think it's 80. It is one of the hardest conditions to treat. They often get in their own way, right? You can't tell these patients that, okay, you're going to feel better in 2 weeks, because like everything they feel, I'm going to die, I'm going to have cancer. And, you know, what is this? Is this new? And what if you didn't discover this, doc? So I think it's more than that, but, you know, statistics say 50%. In bipolar disorder, lots of treatment resistance, right? The depression is the hardest to treat. 2/3 don't respond to first-line treatment. That's pretty scary. And high risk of suicide with bipolar depression, right? So what do we do here, right? Seeing all this in my own clinical practice, 10+ years of it, medication after medication, resistance, medications. So I figured, you know what, there's something more to this. What can we do to treat a psychiatric patient better? So I started with genetic testing. That's when I learned about genetic testing, but I didn't think it was perfect. Why? Because I was only looking at the do's and don'ts, the pharmacokinetics, right? Like if they metabolize it right, if they don't metabolize it right. What I failed to consider was pharmacodynamics, which is just as important. And we will get to it at the end of the lecture, what I mean by that, okay? So I got into integrative medicine for mental health, otherwise known as holistic psychiatry. You know, let's look at the patient's lifestyle. What are they eating, sleeping? Are they exercising? What is their medical status? Is there inflammation? Do they have viral issues? Nutritional status? What are their vitamin deficiencies? Can they metabolize certain vitamins? And so it's really a moot point if you tell them you got to take these things, but their body doesn't even metabolize it. Well, what was the point? So that also gets in the way of how they can be treated and how their depression can improve. So it wasn't also, if you did not correlate supplements with even other factors, including genetic testing, we're missing a key link to try to get the patient better. So I added TMS, and it's a great option, non-medication, non-invasive treatment. It is 60%, I would say, effective. With us here in the office, we actually, based on what we've seen, it's about an 80%. So, but of course, when you think about that, there's that 20% failure. But before we just go on to discussing that, what does TMS do? It targets the DLPFC, the dorsolateral prefrontal cortex, which is what holds all the good feel neurotransmitters, serotonin, dopamine, norepinephrine. And also TMS can help release GABA, anti-anxiety, which is a great thing because that's probably one of the reasons why it is effective for OCD, which is a new FDA indication. So that's exciting to know. But the biggest thing in terms of benefits of TMS is brain healing. And how does it do that? Brain-derived neurotropic factor. It helps increase it. So regardless of whether you're able to even make enough of your BDNF or you've had brain injury, you need more BDNF because that is a protein to help increase the brain's ability to heal itself. It is a great thing. So think about this. Depression comes from the brain. If it's not healthy, it is not going to get better no matter what you try to do to the patient. So you got to focus on getting that brain healthy. So last but not least, hormones. I found that is the missing link in how to get a patient better. My mentor, Dr. Mark Gordon, always said, it is not treatment-resistant depression until you look at the hormones, especially in somebody who's had traumatic brain injury. I think we all know classic TBI, but there are such things as mild TBI that comes from falls, whiplash, blast injuries. Our veterans are exposed to high explosions, or anybody who in their occupation exposed to high explosions. The brain gets jarred in there, and the skull is full of jagged edges, right? I think we all seen that in our anatomy class. You look at the skull, inside of it, it's all sharp. So imagine that brain in just a little teeny tiny in between cerebrospinal fluid getting knocked around in there, whether it's a direct impact or not. The brain moves in there like a football in a fishbowl. So one of the things I learned in one of the first TBI lectures I attended was that if you have a male complaining of depression, you better check their testosterone level, because you can give them all the medicines in the world and you think it's great. But if you don't check their hormones, you're missing a big key why this patient does not respond to your standard treatment. So come to this. I've come to realize that like looking at all those different components individually does not help. I saw a pattern where we have to come full circle when it comes to genetics. Genetics affects our ability to determine whether somebody is going to metabolize certain supplements or not, or our ability to say what kind of hormone levels we will find in someone, or their ability to respond to TMS. Okay, so I think this is one of the reasons why some people don't respond to TMS, because we're not considering their genetics. We're not considering their ability to make dopamine or serotonin or epinephrine, as well as we're not considering their ability to metabolize the dopamine. I've seen this in clinical practice where the effects of TMS can only last for so long, or they don't work, because I did not realize that they were metabolizing dopamine way too fast. So now that I understand that, I can go back and say, we got to support this, and we're going to have less resistance, even when it comes to TMS. And of course, hormones, we discussed that. Genetics can tell us what hormone levels that we may be able to see in someone. So looking at all this, there is a correlation between all four things. And I thought, like, will this look the same in everyone?
No.
Exactly, right? So that's why we came up with the concept of precision psychiatry. I didn't come up with it, okay? It was actually some people from Harvard who thought this was applied to a lot of medical care now. That's like something new. but it happens in psychiatry. No two people are alike, right? Because we're all individuals. We all have different genetics. We all have different experiences, trauma, and just lifestyle experiences that we've gone through. So how do you define precision psychiatry? That is using biomarkers, in other words, labs, including genetic testing, to get to the root cause of the psychiatric problem. So the advantage of precision psychiatry is that I want everybody to know that do we have people have difficulty coming to see a psychiatrist, right? You can tell them, you need to talk to someone, you need to see a psychiatrist. And they're like, oh no, I'm not, crazy, right? They're like, I don't need this. But ever since I started implementing this, I have people who really don't even have a lot of mental health issues, but they come, it's like, well, I'm curious, like, I heard you did this for someone, and I want to know, like, what my labs, what my genetics looks like. And so in a way, that takes away the stigma, right? If I can pretty much almost guarantee that I can find a cause for why you feel bad, that it's not just always your fault, like non-compliance or things like that is the reason why you suffer from a mental illness or why you have treatment resistance. Trying to explain to them clinically that, it is a genetic issue, it is a hormonal issue, it is a metabolism or vitamin issue. Trying to address those things kind of removes that stigma, and the patients actually get more compliant because you put the power back in them, right? So here, we're not blaming the patient. And with this, we came up with the Brainwell program. I was using it mainly to deal with hormonal imbalance and so forth. But then hormonal imbalance can come from anything, right? Menopause, all kinds of different things, inflammation, as well as head injuries. So I realized no matter what causes a patient to have difficulty getting better, and the main drive of it is inflammation, what we want to do is try to control that inflammation. And how do we do that? It starts with getting the brain healthy through the Brainwell program. Because some people say, I never had a head injury. And you're right, you probably didn't. But why are you having difficulties balancing your hormones? Why are you feeling bad? Why are these things happening? So the purpose of it, yes, we need to heal the brain. And how do we do this? A comprehensive workup, which we're going to get to, and come up with a complete treatment plan that is unique to the individual. Because I don't believe in, I would say, protocol medicine in a sense that everybody gets the same treatment, because what will be helpful to one may not be helpful to the other, may make them worse. So I always tell my patients who are part of this program, don't tell people what you're taking, because what would be good for you would not be good for them. And vice versa, because this is basically a culmination of like all my experience with just general psychiatry, as well as learning and asking questions and so forth, and then starting to see a connection between all those components that I discussed earlier. And no two people are alike, always, okay? And so I think that's also the missing thing, that when it comes to treating patients, we have to treat them as unique, as individuals, and go through the background of what they've been through, as well as family history and so forth. What is the goal out of everything that we do here? When we find the actual cause of why people feel bad, we give them the plan, and they'll get the long-lasting results that they've been looking for. So who can benefit from this program? Like I said, this approach takes away the stigma of having somebody get mental health treatment. With our workup, we always find that there's something wrong. So we're not putting the blame on the patient. Biological makeup, is one of the reasons why they may have some bad behaviors, and people struggling with depression, anxiety, mood disorders, substance abuse, traumatic brain injury, menopause, and insomnia. So any of those situations, the Brainwell program can help. But if you look at all these things, okay, traumatic brain injury, they suffer from depression, right? Suicidal thoughts, menopause, and insomnia, and anxiety, memory loss. Okay, so anybody who's suffering from all these things can benefit from a more comprehensive approach to the Brainwell program. Okay, so what are the outcomes? You feel better, resolution of your depression, anxiety, mood instability, psychiatric issues with long-lasting results. You live better. How do you do that? You're taking care of yourself better, right? And because we know what the root cause is, then these patients understand that it's just not them feeling bad. You know, help them find what is the cause of their mental health issues. Knowledge is power for these people, right? And then putting them responsible of knowing what they are struggling with. It gets them to be more adherent, and they function better, improve energy, better concentration, live an optimal life, better relationships. Let's see. Yeah, I would say this program helped the marriage. Somebody came to me with they thought they would just like come in and get some refills because their doctor retired. So I said, well, let's talk about let's get your genetics done. Found out the reason why she was taking so much Xanax was because she has a dopamine metabolism problem, which it's too high. Okay. So when you have dopamine, the usual treatment is like dopamine blockers. So in these cases, that's what I did. And just 5 milligrams of Abilify basically saves her marriage. Her husband confirmed it. She's better. She's no longer overreacting to things. We're getting along. It's calm in the house. I'm not walking on eggshells. And so that is the point of why we want to get mental health. We want to get healthy because it doesn't just affect us and our ability to function, but it affects everybody around us. So knowing the cause, we can get to it and we can try to help them overall achieve life satisfaction in everything they do. So the protocol is patient comes in, we do a psychiatric eval. That's where we order genetic testing. Okay. When they come back, we review it and we come up with a treatment plan. And if they need hormone replacement, and that's what we need to do, we need to do that. We do that with a neuroendocrine analysis. And that's just not talking about sex hormones, because people think hormone replacement, that's all there is. And when it comes to mental health, we need to know why these things are low, why these things are off balance. It comes from the brain, right? So we need to know, are things going on in the brain that is not making all those peripheral hormones, your thyroid, your adrenal, your sex hormones, why those things are low. So if that happens, then we do further workup, and then we come up with a protocol for that. Okay. So the psychiatric eval is 1 hour appointment. This is where we talk about signs and symptoms, past treatment responses, medical history. Always ask for head injury. And even if the patient tells you no, because I had the same situation happening yesterday, I was like, have you had any trauma, accidents, so forth? And then even with that, they said no. And then I asked them, have you had injury? Oh yeah, I've had concussions and, and I'm like, okay. So always ask for that. Even infections causes a lot of inflammation. COVID is bad, right? Other than people complaining they can't smell, they can't think, they have foggy brain. What I found out, or what if researchers found out, is because causes inflammation in your blood vessels in the brain. So we have to focus on getting the brain healthy. But we got to elicit all these things. What is causing a patient to have an unhealthy brain? And along with medical, of course, we have to ask, history of abuse. Sometimes they won't always tell you. Yesterday too, I asked the patient, have you ever gone through any trauma? No. Wife says, yeah, he had a gun pointed to him 3 times by the police. That's pretty traumatic. It jars you, right? You may not have thought about it, like it didn't, but all that increases your fight or flight. So, as well as relationships, are they toxic? Are they helpful? And we have to ask about substance abuse. Why? Because that is toxic to the brain. It is not as healthy as some people think. I was at a substance abuse conference that basically said the most infamous plant that everybody thinks is great for them, right? He said they're not, they're the enemy. So we need to ask these things about substance abuse. So what are the things that we look for in the labs? When the patient comes back to me after initial follow-up, I always start with where it all begins, right? Genetic testing. And I'm just going to pick through a couple of things because next month is going to delve more deeply into genetic testing. So let me just pick on the top 3 that I look for. And there is a company that I prefer over one or the other because they will look for these things in them. Okay. So BDNF, I talked a little bit about that. It's a buzzword right now, but like I was trying to figure out what this is, but really it is a protein in the brain that helps in the plasticity of the brain. That means the brain's ability to heal itself. And it helps with brain connections. And it is very important to know this, especially when it comes to people who've had brain injury who continue to suffer from cognitive deficits. I have a patient who is a NFL player, 10 years. Of course, as you know, those are the people with CTEs and constant trauma to the brain. Why is it some of them don't recover from a brain injury better than others? Well, it has something to do with BDNF, and how you can tell that is through genetic testing. It'll tell you this person has a poor ability to make it, and simple things can be done to treat it. But if you don't know the answer to the question, then you don't know which way to go and how to treat the patient and get them better. And that patient, even after 2 weeks of the treatment I told him to take, able to function better, focus, concentrate better. I noticed he wasn't stuttering as much, even after a couple of months. And then he just told me last week that he credited the program to actually helping him to have the wherewithal to finish editing his book and so forth. So that was a really good feeling to know, but all because we found out his BDNF was not working right, or he was not creating enough of that. So that was a really good story to just share. That was amazing. MTHFR, I think we all know about this, right? Sort of. It's just, what I knew about MTHFR 5 years ago is totally different from what I knew about it, just like now, or even 2 years ago. It was sort of revolutionary to help us explain why some people do not have the ability to respond to medications. What if you can't even make your own serotonin, dopamine, or epinephrine, right? So that's why you have treatment-resistant depression with these medicines. They will not respond because drug companies fail to really say, we don't help the patient make this stuff. We only help them keep it around, right? That's what the names are. Reuptake inhibitors, SNRIs, SSRIs, even dopamine. Wellbutrin is the same thing. The concept is keeping the dopamine around. What if you can't make it? Then there's no point of like what you're doing with it. That's why the treatment L-methylfolate has already been shown to help treat depression. Because if you don't have enough of it, then you need to replace it. So it's just like a diabetic. You don't have enough insulin. You need to give yourself insulin. So it's the same concept. It is a genetic issue. So the last thing that I want to just touch on a little bit is the CompT. CompT is it was very difficult for me to even find the information because I even asked some of the smartest people in the country, and they couldn't even give me the concept of like what it is. I don't understand this. Well, the whole premise is metabolism of dopamine, right? So if you have a poor ability to metabolize dopamine, you're going to have an elevated level, right? If you have a high propensity to develop to metabolize, it's going to be low. So this is the most interesting gene for me because it is not a standard like one type of treatment. Oh, your CompT is abnormal, so this is what you do. No, you have to look at what it is, what it's doing. So when you have high CompT, that's what you call the warrior gene, right? These are the people who can't sit still, who actually do pretty good in chaos. You know, there are good things about them, but then this is also what I see with people who are prone to ADHD. So I like to call this the ADHD gene, okay? Not the CompT gene, the high CompT gene, okay? The other way around, you got the warrior gene. These are the ones that have high dopamine. They don't like change. They're obsessive. Sometimes they don't always play well with others, but it's not that they don't mean to do that. It's just that they have their own set ways. Because if they don't have it this way, all chaos happens and they don't respond well to change or any chaos or change. And they're great when they're left to their own little corner to do their own thing. You can always rely on them to do the job, but just don't give them too much because you know how the term no good deed goes unpunished, right? You're doing great. Let's add this to it. And all of a sudden they're like having meltdowns and we're like wondering what happened. Some of these patients that come to me like this, they had no idea. And this is what I find. And then once I found that out, you know, like, okay, the good news is the treatment for any type of catecholamic methyltransferase enzyme, whether it's high or low, is lifestyle. And that empowers people to say, okay, I have to change my diet a little bit. I have to do certain kind of exercises. And for people who are the warrior gene, they may have this overreaction, but you tell them it's going to be okay. You just react to it more than others, but you'll come down to earth and it'll be fine. And they actually feel better knowing that. And some of these patients don't even have psychiatric medicines because they know what is the problem. And that's a good feeling to have because you put the responsibility on the patient. And because the more you educate them about their problem, they actually, like some patients have cried and said, you know, it's just not me and how I think and how I behave and so forth. And it's like, yeah, this is how you are made. But these are the things that we're going to do to help you deal with that. So the depression panel, we look at vitamins, mineral deficiencies. Vitamin D, I found can also predict thyroid results, especially Hashimoto's. Viral infections. There is such a thing as we know, mono infection. Mono infection can cause a delayed overreaction, immunologic response, and cause a lot of inflammation. That's why you see not only with us, but like a lot of these patients who said, yeah, I've had mono and I'm like tired 6 months later, and we don't believe them. But then we look at their viral loads and it's like, yeah, it's possible that you're still suffering from that. And there's something else that's causing them to overreact. We don't know. Could it be an environmental insult? We don't know. But at least we know this is happening. They're inflamed. Even if I didn't look at somebody's genetics, I can see not 100%, but like if I look at somebody's genetics and say their homocysteine level is elevated, what do you think, what kind of genetic problem they would have? think about homocysteine and where it comes from, or what happens to it, why it becomes normal. Homocysteine is metabolized by the L-methylfolate to become serotonin, dopamine, or epinephrine. In order for someone to be able to create those things, homocysteine is involved in that, and L-methylfolate is also involved in that. So homocysteine is elevated. That means no L-methylfolate is happening, okay? And this doesn't just apply to psychiatry. As you know, people will elevate homocysteine level, cardiologists check that, neurologists check that. It makes them prone to blood clots, right? Strokes, heart attacks. And so this is just not applicable to psychiatry. You wouldn't believe the patients that came to me and said, I've had a stroke, and they were MTHR deficient, and said, you need to take your L-methylfolate. Doesn't know necessarily the case where your MTHFR is deficient and you can have elevated homocysteine, other things going on, inflammation as well. But that's something to think about in the back of your mind. And the one other thing that I also look at when it comes to vitamin deficiencies and metabolism, you need to think about B12. Sometimes when somebody's MTHR deficient, they are also B12 deficient, metabolism of it. So that's why in the protocol that I set for in our clinic, it checks for methylmalonic acid. So this is the reason why I'm also not a believer in people who are getting B12 shots left and right for energy. What if they can't even metabolize the B12, right? The way you can tell, methylmalonic acid is elevated. And how do you treat that? You give them the methylated form of cobalamin. Okay. And so, of course, we also look for, vitamin D levels, magnesium, low mag, what happens, you have anxiety, zinc deficiency. What do you think can happen if you have a zinc deficiency in your hormones? You can have testosterone level that is low. Zinc helps testosterone to be kept around because it prevents it from converting to estrogen. So you can find a lot of information in the depression panel. And anyway, so let's talk about hormones. We test everything. I talked a little bit about vitamin D and thyroids. There is a connection. I have actually, what is the marker for Hashimoto's in a blood panel or a hormone panel? What do we look for? We look for the TPO. Yeah. So I have patients who come to me with elevated TPO, vitamin D deficient, corrected the vitamin D deficient, TPO is normalized. And why is that important? Because the TPO, it attacks your own thyroid glands, makes it inactive, right? And then you just put yourself in hypothyroid. So we can help somebody's hypothyroidism by normalizing their vitamin D. It can happen, okay? All right, of course, it's very important to check these as we talked about when it comes to traumatic brain injuries. You gotta check their hormones. And let's go back to what do we mean by brain injuries? It's not just physical. It could be a stroke, it could be a heart attack, going through a long duration of surgery. All those things are harmful to the brain, along with the drugs and all kinds of inflammation that can happen. So in a hormone panel, we can understand why somebody could have anxiety and insomnia, and looking at somebody's progesterone level and pre-hormonal progesterone can help us understand why they may not have good memory, they may not sleep well, and they may be anxious and nothing works. So we talked about that way, we look at the brain, look at the thyroids, adrenals, sex hormones, add in their growth hormones. Growth hormone is very important. I now have a portion of the Brain Well program that focuses on weight loss, and growth hormone is a very, very important part of that we don't think about. So it's more than just little kids, getting the height that they need, that there are other benefits to it. Okay. All right, so let's talk about the treatment when it comes to, once I know all these things, we come up with a plan. We talk about supplements. Antioxidants is really good. We give vitamin C, D, and zinc. Glutathione can also help decrease homocysteine level if the L-methylfolate is not doing it. Of course, looking at the labs, we can determine, should we give them folate or L-methylfolate, or should we give them B12 or a methylated B12? Okay. So genetic testing, this can help us guide or help us predict what medicines to give, what meds to avoid, less shot in the dark approach. Lifestyle, let's talk about lifestyle. The lab work will help us determine, are you going to benefit from a high protein diet or low protein diet? Are you going to benefit more from vigorous exercise, cardio, or more relaxation exercises? And also telling them what are the things you need to do to avoid that are bad for the brain, staying away from toxic things, including relationships, right? That is part of your lifestyle. I mean, if you've been in a relationship that's just really bad, and telling them that either, you either cut it off, or you're going to have to figure out a way to not let that relationship, that bad relationship, get the best of you. Sometimes it's good to tell these patients because you empower them. Okay. So let's talk about TMS. By the time the patients come to me, they're already basically treatment resistant. They've seen everybody, nothing works. But going back to genetics, I won't even recommend TMS unless I know what their dopamine status looks like, because I need to know whether I need to support their brain so they'll get the best out of TMS or not. So knowing that, then we can let the patient know, you will benefit from TMS, but I need for you to do A, B, C, D. And of course, we want to stabilize their hormones. Okay. And we're not just talking about, hormonal abnormalities. Okay. So oftentimes, these patients who do have hormonal abnormalities, we talked about it, but they can have psychiatric symptoms: depression, suicide, foggy brain, can't sleep, weight gain. When it comes to weight gain is actually a brain disease. Why? Because it is controlled in the hypothalamus. The MC4R receptor is the one in charge of metabolism. If you have a brain injury and it hits the hypothalamus, guess what? Your own physiology of metabolism does not work. So there are other things we can do to address that, but we need to consider those things. This can benefit the geriatric population, people who are struggling with menopause, andropause, those sorts of things. You will notice that if you stabilize their hormone levels, they will feel better. Their metabolism will work right. Of course, we talked, and then the last thing we talked about is hyperbaric treatment. If all else fails, this is the last thing we do. We do have a protocol in place. We haven't really used it yet because I've actually done a pretty good job at using the first 4, and patients will get to a point where if they're adherent, they're going to get the results that they're looking for. But, I'm not taking off hyperbaric therapy off the table. If the patient can afford that and can have the luxury to do that, I say go for it. Okay. So in the Brain Well program, it is genetics. We focus on genetic testing, mostly on pharmacodynamic, that means the body's ability to make things such as the L-methylfolate, body's ability to how they metabolize things, and the body's ability how to make BDNF. Not so much in the pharmacokinetics. I mean, that's pretty much a given. The thing we have to remember is you can look at all the pharmacokinetics and what meds to give, what not to give. But if you're not considering their pharmacodynamics, you're actually going to make the patient worse sometimes because you're giving them things that are not really the best for them. Okay. So like an example, somebody who's MTHFR deficient with low COMT, what does that mean? Somebody who can't make serotonin, dopamine, or epinephrine, right? But the little dopamine they have around, it stays around, right? It doesn't go away. So this was the reason why I started seeing patients that, oh, you have MTHR deficiency, take your L-methylfolate, and they come back 2 weeks later, I'm anxious. And I didn't understand that, but because I didn't look at their COMT metabolism. What you've done is you fueled the fire. So in these cases, sometimes it does make them more anxious, sometimes it doesn't. So I warned the patient. I said, okay, we'll give you a lower dose of it, but if you start to get anxious, then you just don't take it. And I have other ways to increase tryptophan and serotonin without increasing the dopamine. And that's another lecture too as well. And we can, there's ways to go around it in order to decrease their anxiety by helping them build their serotonin without worsening their dopamine level. Okay, so that guides the rest of your treatment. This actually will guide your ability to say what kind of sex hormone treatment that they're going to get. I've had a situation where I didn't know the patient was low COMT and I was giving him testosterone or things to stimulate, and he got really anxious, and I redid the test because it didn't have it the first time around. And I was like, oh, like with the testosterone, because he was like brain injury and he was depressed and sitting at home and not doing anything, increased the testosterone. Yeah, he felt good, the first, second month, third month. So I'm getting anxious. And I finally was able to look back and say, okay, we repeated the labs. Estradiol was so high. So we had to bring that down, minimize the body's ability to make the testosterone, but still try to bring it all balanced. Anxiety went down. So lots of things you can learn just by looking at somebody's genetics and how it can dictate the rest of your treatment. And of course, genetics, if you don't look at somebody's genetics and you start giving them things that, so we talked about with L-methylfolate and they have low COMT, you're going to have a bad outcome. But if you know that already, then you can be more careful. You can watch it. The genetics and the right kind of supplements will help somebody to respond to TMS better than the average numbers. Okay, and you will have longer response to it. And of course, if the patient is not doing well with TMS and supplements and genetics, we're not missing the piece of the puzzle that, hey, what if they are hormonal deficient? What if they are low progesterone, low pregnenolone, low testosterone, and they're having difficulty losing weight despite of their eating right and their exercising right? What if they have a deficiency in their growth hormones, as well as what if they're having problems with insulin resistance? So doing those things, lifestyle measures, we can still make those recommendations. But however, if we don't know what we're dealing with, we don't know the direction we're going to. But doing all these things and knowing how they do connect, because no one taught me that. I had to figure it out and bang my head. Oh, learning this. Oh, this is how it happens. And now we have a safer method in how we can get our patient better, right? Okay. All right, before I talk about any other cases, is there any questions at all? Like anything at all?
I do have a question.
Okay.
When you mentioned, low content,
Mhm.
you're talking about men.
Yes, yes, yeah, met, and then, I would say, just when I learned all what I needed to know about CompT, low or high, I started looking back at all my patients and I said, 80% of my psych patients are either high or low. And it starts from there. And the good news is, if you know that, like, okay, somebody who comes to you for ADHD and they have Val, was what you see in the genetic testing, you can give them lifestyle measures to help create their own dopamine. They don't have to be loaded up with Adderall, or because that's impossible to find right now. And so maybe they won't need as much of a stimulant. If you tell them high protein, you got to exercise, take this supplement that increases dopamine. Okay. All right. And then, of course, when they're like the opposite, low protein, relaxation exercises, things that will elevate their serotonin naturally without elevating dopamine. And can a person with MET have ADHD? Yes, it can happen because they still meet criteria, because they can't focus, concentrate, and all that. But it's because they have way too much dopamine. They're so anxious, they can't think right. So that's why, in theory, medications like the Integrative works better for them, because it brings down the hyperness that's coming from the dopamine, too much of it, and it tempers that. And that's why Integrative works for some people for ADHD. It doesn't do anything for people who have high CompT, because you're just blocking something that they already lack. So you're already now putting the science into clinical practice and telling people, and I've had really good results with patients who have had ADHD, and I was giving them a bunch of stimulants and they were like low CompT. And then, of course, with this whole Adderall shortage, they were finally open to suggesting, hey, try some Integrative, and they realized that worked without worrying about going in a shortage. So it actually even works pretty quickly compared to like what you think it would not do, but it does. So, but of course you have to educate the patients, like, listen, too much dopamine in you, that's why you can't focus and concentrate, you're anxious. So we need to tamper that effect. So, all right, anything else? Any other questions? Okay, all right, thank you everyone for coming. Next one will be when?
March 24th.
Okay, March 24th, same time, same bat channel. But this time I will really get into genetic testing and really, like, I'll even talk about what are more clinical things we can do. I talked a little bit about today, but not the way we're going to delve into it even better. All right, bye now.